Hello everyone. I'll be talking on posterior and panuveitis strategies to overcome management challenges. I thank the organizers of the UVA for all to having me here, and it's a wonderful opportunity and proud honor for me to join the Arvind Eye Hospital CME. So I'll be talking about a little bit of posterior uveitis and little bit of the anterior panuveitis and how to deal with these challenges. So as you know, the posterior uveitis is defined as a uveitic entity where the primary site of the inflammation is retina or choroid. And panuveitis is defined as a clinical uveitic entity where there is inflammation in anterior chamber, in vitreous and in retina or choroid, but nobody is sure which one is the predominant site of inflammation. So in such scenario, we call this entity as panuveitis. Now, we'll be discussing this entire talk in four broad headings. One is that yellowish white lesion in fundus, whether it is a retinitis or choroiditis. We'll also talk about certain uveitic conditions where there is no view of the fundus mainly because of the vitritis. And also we'll be discussing about hot-headed fundus where there is the optic uveitic entity is characterized by optic disc involvement. And also, we'll just touch a little bit about the fluid in the fundus, where we'll just try to delineate some cases of the exudative retinal detachment. Now, coming to my first topic, yellow lesion in fundus. So first, one question the clinician should ask himself that whether it's a case of retinitis or choroiditis. In case of choroiditis, it is characterized by grayish yellow patch, fairly demarcated border, and retinal vessels can be seen normally. Whereas in retinitis, it is characterized by white cloudy patch, indistinct outline, and retinal vessels are obscured. For example, you can see here, you can't make out that retinal vessel because it's above the retina. So I'll show you another graphical representation which will make it more clear. Now, for example, here, how clearly you can see the retinal vessels in choroiditis? Answer will be yes, I can see it clearly. Why? You can see in this graphical representation where you can see that the blood vessel is above the yellowish white lesion in the fundus. So that's why in choroiditis cases, you can see the blood vessels clearly. And whereas here you can see there is a case of retinitis and you cannot see the retinal vessels clearly. The reason is that yellowish white lesion, as you can see in this graphical representation, it is above the blood vessels. So that's why you can't see the retinal vessel clearly in a case of retinitis. Now, let's come to the clinical phenotype recognition in such case of yellow lesion. Now, don't fall prey to the umbrella terminology. Uveitic is a condition where we use umbrella terminology to categorize all this kind of inflammation. For example, we call it choroiditis, we call it retinitis, we call retinochoroiditis, which we all several terminology comes under one umbrella. Now, for example, if you ask me to define, the retinitis is a non-specific term to describe the retinal tissue inflammation, which can have different etiologies, and the different etiologies will determine the different clinical picture, and the treatment of this condition will vary according to the etiology of the condition. So that's why it is not that you can treat a case of retinitis, or you have to understand that it's an umbrella terminology and you have to decode the cause of retinitis and then only you can treat it. Now, remember one very important point that retinitis is almost always infective except in two conditions. Now, let's see which are these two conditions. The number one is Behçet disease. In Behçet disease, you can see some retinal infiltrate which may mimic like multiple retinitis. The clue to the diagnosis is if you take the history, you can actually get a history of oral and genital ulcer, and also you can see the presence of retinal vasculitis. Now, coming to the another another variety of this condition is that intraocular lymphoma. Now, in intraocular lymphoma, you can see the cream-colored multifocal subretinal pigment epithelial infiltrates, and this actually can mimic a case of retinitis. Now, this is very common in elderly patients, and they tend to have more recurrent vitritis. CNS imaging is common, and vitreous biopsy can be actually diagnostic. Now, the next important point is that retinitis, the clinical phenotype of the area wise. Now, first, let's look into the peripheral confluent retinitis. So here you have to understand one condition is that there are some retinitis which can involve the periphery. And if you are not examining the periphery in those uveitic entity, only examining the posterior pole and the anterior chamber, you may miss the diagnosis of those retinitis and only treat them as an anterior uveitis. For example, here you see a condition where if you only examine the posterior pole, it largely looks okay except for some hyperemic disc. But if you dilate and see properly, you can make out that it is a case of acute retinal necrosis. So the lesson is that you should not forget to examine the retinal periphery carefully. Now, when we are talking about ARN, you have to understand that ARN is characterized by a triad of clinical signs. The first one is retinitis. Now, what are the characteristic of this retinitis? It is peripheral areas of confluent retinitis, which has scalloped edges and discrete margin. Now, it starts in periphery. Why it starts in periphery? Because it may correspond to the termini of the ganglion cells, which is the cells located in the nerve fiber layers. Now, also you can see the occlusive vasculitis, mainly the arteritis, and which is characterized by some amount of hemorrhages. And then you can see the vitritis. Now, the vitritis in these conditions are basically the necrotic retinal debris, the product of inflammation, which is continuously being sloughed off by the viral particles and being poured into the vitreous. Now, one important point to take from this lecture is that it is acute retinal is dreaded entity, and if you are not treating with systemic treatment, the fellow eye involvement can happen as early as 6 weeks, and it can be a potential blinding conditions. So, acyclovir treatment or treatment with valacyclovir lowers the fellow eye risk from 24.7% to 24.7% from 64% at 2 years. So this is very important point. So the treatment with systemic antiviral is very important. Now, I can show you here a case of 29-year-old male who presented with sudden diminution of vision of 1 week duration, and it was diagnosed as a viral retinitis and treated with injection ganciclovir. Was planning for ganciclovir injection, and then we decided that we'll just start investigating this patient. And when patient arrived in Chennai, and we started we sent the patient to neurologist, and I literally asked the neurologist, "Can you do a CSF tap?" And the neurologist was telling that the EEG is normal. There is no neurological symptoms. Why you want to do that? But somehow I convinced the neurologist, and the CSF tap was done. And you can see that anti-measles antibody was significantly high in this condition. So this is how you can ask me that how this kind of diagnosis was made. So one characteristic point in this measles retinopathy is that you can see this ballooning of the internal limiting membrane, and with the clinical suspicion, high index of clinical suspicion, I must say that you can actually clinch the diagnosis. So one thing must remember that this is a potential devastating condition and almost always fatal, and systemically administered interference cannot prevent death in this patients, though there are some improvement in the symptoms have been reported in some patients. Now, say another important thing you have to understand that the vasocentric retinitis. Now, this vasocentric retinitis, when we talk about vasocentric retinitis, you have to understand the most important cause is CMV retinitis. It can involve the young, healthy male to elderly person, and can be bilateral in 30% of the cases. Now, this is asymptomatic in 50% of cases, and characterized by white and quiet eye, and usually no or very minimal vitritis is seen. So it can affect the posterior pole also, and it can actually involve the periphery or both. So one important point you have to understand that a fundamental difference between HSV, VZV, and CMV is that CMV usually affects the immunocompromised patients, whereas the HSV, VZV involve the immunocompetent patients. Now, HSV and VZV enters the eye through the neurons, whereas the cytomegalovirus enters the eye through the hematogenous route. Now, unlike HSV, VZV, the CMV replicates very slowly. It is said that approximately every 18 hours. Thus, the retinitis in CMV has a slower progression. Now, there are broadly three kinds of lesions can be seen in CMV retinitis. The first one is fulminant, which we commonly see, characterized by pizza pie retinopathy-like appearance. Indolent variety can have that mainly involve the periphery and very little hemorrhages. So if you are not aware of that, you can miss it and may not consider a diagnosis of CMV in such cases without hemorrhage. Now, always pay attention to the history of immunosuppression. When I say that, we always think about the systemic immunosuppression. Yes, it is very important. You have to rule out HIV in all patients. Any therapeutic immunosuppression is happening or patient is under any immunosuppressive. You have to understand that. The another important point we always miss is that local immunosuppression. So history of intravitreal injection is very important in such conditions, and you have to take the history of that. Now, let me show a case of young female who presented with diminution of vision of 2 months, history of dengue fever for 4 months back, and she was diagnosed with skin lesions, and the biopsy reveals pyoderma gangrenosa, which is treated with cyclosporin. And so it was you can see the fundus photograph of the patient, and it was diagnosed as CMV retinitis, treated with intravitreal ganciclovir in multiple ganciclovir injections, and HIV was negative. So what hounded us was that what is the cause of CMV in a young patient, because she was not having any immunosuppressive drug or anything which can actually lead us to a diagnosis. So finally, we decided we'll just go for a PET scan, and that PET scan revealed that hypermetabolic annualized supradiaphragmatic lymph nodes, and CT guided biopsy with an oncologist revealed that it was a case of diffuse large B-cell lymphoma. Now, so what we learned from our evidence-based literature that, so don't rely on serology as laboratory investigation diagnosis of the herpes viruses. See, these torch titers, many of us do, and we try to diagnose conditions based on that. But if you see here that 92% of the humans shed HSV1 DNA in their tears, and in another autopsy examination, it was found that the 93% of the human revealed HSV1 DNA in their trigeminal nerve. And PCR from the ocular fluid remains the gold standard. And two serological tests you must do is all cases of retinitis is syphilis and HIV. Now, coming to that syphilis, if you see this entity called ground glass retinitis. Now, what is that? If you see like presence of sometimes the small creamy white superficial retinal precipitates with retinitis and this kind of picture, then you have to suspect it as a syphilis. Now, the retinal involvement in syphilis has an opacified appearance, which is distinct from the typical white and necrotizing retinitis seen with the herpetic lesions. So one must be able to diagnose the herpetic lesions and the syphilitic lesions from the clinical finding. Now, there are we call it many phases of inflammation. Some conditions like syphilis and tuberculosis and many more conditions has not a definite form of presentation, and they can mimic any kind of uveitis, and so we call them masquerader. So syphilis and tuberculosis are the king of masquerader. Now, coming to the choroiditis, the most common choroiditis we encounter is that map-like choroiditis. And you can see here, this is a 24-year-old presented with sudden diminution of vision in right eye. And you can see here large choroidal lesions with a wavy border. and this is called serpiginous choroiditis. If it is autoimmune, then we call it serpiginous choroiditis. If it is infective etiology, for example, tuberculosis, then we call it serpiginous-like choroiditis. Now, serpiginous choroiditis, as you can understand, it is treated with steroid and sometimes require immunosuppressive to prevent the recurrences. Whereas classically, the serpiginous choroiditis is treated with systemic corticosteroid and anti-tubercular medications. Whereas nowadays we feel that sometimes this kind of cases also recurrence needs your immunosuppressive treatment. Now, another variety of lesion we can see here is that multifocal choroiditis. And you can see here sometimes what happens, these are the starts as a multifocal choroiditis and they coalesces together to form a map-like pattern. So this is very important to understand that sometimes we can see that empygenous-like choroiditis patches, and if we, in absence of treatment, they can coalesce and form a map-like pattern. So another important point, clinical phenotype is single and solitary choroiditis or tubercles. So this is the most characteristic form of ocular TB, which is most commonly seen in posterior pole or mid-periphery. Now here is another, you can see here that the sarcoidosis cases, and sarcoidosis cases, mostly these tubercles are post-equatorial and mostly seen in the inferior knee. However, there are another variety of nodules, and you should not confuse them with sarcoid or TB. But this Dahlen-Fuchs nodule can also occur in sarcoidosis, but also seen in VKH and sympathetic ophthalmia. Now, the granulomas are another yellowish-white pattern that can confuse you. So the tuberculoma and sarcoid both can have. Now let me just try to decode it, though sometimes it's very difficult to differentiate them clinically, but very important points can be remembered as follows. The tuberculoma, usually they are unilateral, whereas in sarcoid it involves mostly the bilateral. And the tuberculoma usually is located in the perivascular area, whereas the sarcoid, it is involved in the periphery, diffuse distribution, and most commonly it is associated with some vascular changes. Now let's come to our second topic, that no view fundus, where you encounter a case of vitritis and you can't see anything in the fundus. Now, it can be, you have to understand that the vitritis is the reservoir of the product of inflammation, and it also can be a part of anterior, posterior, or panuveitis. So in this scenario, you have to always look for the other clinical signs, subtle clinical signs, take some history so that you can at least diagnose it. For example, no view fundus with vitritis can be most commonly seen in acute retinal necrosis, toxoplasmosis, toxocariasis, and in VKH. Now, sometimes you will see that the fungal infection can actually present as a vitritis. So you have to be beware of that, and you have to understand that you need to rule out the endogenous endophthalmitis. So why I am talking about this? Because you need to understand that the panuveitis and endogenous endophthalmitis can have a similar and same kind of clinical presentation, and you can burn your finger if you mistake them and treat them because the treatment is almost paradoxical in nature. Now, another important point, you have to understand that the vitritis in elderly sometimes can be early signs of lymphoma. So you have to treat them properly. This kind of vitritis always responds to corticosteroid and recurs when it is stopped. So now coming to our third point, that hot-headed fundus. So this means that somewhere the optic nerve head is involved. So the characteristic examples are the sarcoidosis, VKH, toxoplasmosis, syphilis, systemic ophthalmia, and Behçet disease. Now, the another important optic nerve involvement is that if you see them with a choroiditis. So 3T you have to remember, for example, TB, toxoplasmosis, and toxocara. These three can cause actually the peripapillary choroiditis and can actually cause optic nerve involvement. So another important point is that neuroretinitis. Now you have to understand neuroretinitis is characterized by disc edema, macular star, and unilateral vision. So unilateral vision is very important because if you see the similar kind of picture, that is neuroretinitis like presentation, and it is bilateral in involvement, then you have to rule out the other systemic metabolic disease like malignant hypertension, diabetes mellitus, and elevated intracranial pressure. Now, there are certain conditions where optic nerve involvement can be seen with subretinal fluid like leakage, posterior scleritis, and sympathetic ophthalmia. So it's important to understand the condition that the optic nerve involvement can have some other conditions also associated with that, and we need to rely. Now we have come to our last part of our topic, the fluid in fundus. So here the most common example I would like to give you is that leakage, the Vogt-Koyanagi-Harada disease, history of headache, tinnitus, white patches, and patchy of hair loss often can give us clue to the diagnosis of that. It is characterized by exudative retinal detachment, multilobular configuration of the subretinal fluid, and pinhead leak, which can show placoid pulling of the dye in fundus fluorescent angiography. So conditions with similar FFA findings like posterior scleritis, punctate inner choroidopathy, the choroidal malignant melanoma. So sometimes we think that if it is showing posterior pinhead leak and the placoid pulling, then it is a case of leakage. But there are multiple conditions where similar clinical picture can be seen. So another same kind of spectrum of the disease, only characterized by a insult in the eye, which can cause the uveal tract incarceration. For example, it can be planned like ocular surgery, or it can be unplanned like ocular trauma. So this condition also can have a similar like picture like leakage and can present with exudative RD or fluid in the fundus. And another most important condition which can have similar presentation is posterior scleritis, which has plethora of presentation and has a pain in eyeball movement, USG B scan, and T scan. T sign is not pathognomic. So here is a big list of exudative RD. I'm sure it's not possible to rule out all. So the best way is to take the uvea related history, go examine the eye thoroughly, take the help of ancillary investigations, then try to clinch the diagnosis. So this is another conditions which is showing that few conditions which are associated with subretinal fluid accumulation in the fundus. For example, first picture you can see this is ocular TV which developed worsening of after ATT treatment and manifested as exudative retinal detachment. There is another picture, exudative retinal detachment with subretinal abscess, and we have exudative retinal detachment in nanophthalmus. So refraction and axial length evaluation can help, and also uveal effusion syndrome, which is diagnosis of exclusion. So try to exclude all other conditions in such scenario. So there is another case of exudative RD. Can you guess the diagnosis? So this is very interesting, and the treatment with uveitic condition is almost paradoxical. So you have to be very careful. Yes, I am talking about a case of CSR. This picture which I showed you was a case of multifocal CSR and mistakenly treated with steroid. So this is just to highlight that under the right circumstances, these conditions can present as a similar with some uveitic entity, and serious consequences can occur if a mistake is made. So my last slide, always remember the changing face of the inflammation, that the granulomatous disease may present with non-granulomatous, mutton fat capies may present in viral uveitis, intraocular lymphoma can present with vitritis, and uveitis is a evolving diagnosis. So you have to understand that these clinical signs often behave as a trap and mislead the clinicians. So the advice is don't fall in love with your diagnosis in uveitis. Uveitis is always challenging and will be challenging whatever and how much you learn from your experience. Thank you for your patience here.